you know, there's an old saying, better late than never, but how about early? I know we're starting about 5 minutes early, but that's okay because our guest has a very hard stop. So I wanted to accommodate him. But remember, you can always watch the replay. This will always be on YouTube. In fact, it's on YouTube right now, live. And I will introduce my guest in a moment, but I just want to welcome everyone to the live broadcast today. Thank you so much for being here. If this is the first time you're seeing me, I'm Chef AJ, and I created these daily lives just to create a sense of community and connection during this sheltering in place. And I've just been very fortunate that I've been able to attract some superstars in the plant-based world, and today's guest is no exception. He is the former past president of the American College of Cardiology. He has a quote that has been used by every cardiologist I've ever interviewed. And you know, last week I interviewed 2 of them. That's one of the things I think he'll always be remembered for. And I'm so honored to have him here. Please welcome Dr. Kim Williams. Thank you so much for being here. We really appreciate it.
Well, thank you for having me, and thank you for all that you're doing.
Well, my pleasure. It's just, I've interviewed you once on a teleclass, but never in person, so it's quite an honor. I know you wanted to talk about what's going on in the world and how nutrition plays a role, so I'm just going to turn the platform over to you.
Well, obviously, we're living in a time that we have not experienced. I know there are some centenarians who actually lived through the Spanish flu epidemic, but they probably don't remember very much about it. It was a different society. We do talk, I actually was talking about the Spanish flu a lot during my talks, and I studied it just because I was interested in the kind of thing that it would take to get to have heart disease be the #2 killer of Americans. And that was the one time that it really did happen. I don't think it's going to happen with COVID because the heart disease has such a big head start. We typically lose about 600 to 650,000 Americans from heart disease. But it's interesting that the things that have been identified, particularly starting off in China and then in Italy, that correlate with a really bad outcome for mortality with COVID-19 tend to be some of the same things that happen for cardiovascular disease. So the chronic lung disease may be an exception unless it's related to smoking, and then it definitely is a risk factor for heart disease and COVID death. But the rest, diabetes, hypertension, obesity, these big risk factors, not just for contracting, for developing a severe level of illness, but being admitted to the hospital and being in the intensive care unit and ending up with a bad pneumonia that requires a ventilator. All of those risk factors seem to be the kinds of things that we really should be talking about. It's the underpinning of the mortality. So when we look at New York, where it's basically Hispanics and African Americans who have this excess mortality compared to the number of people in the population. Here in Chicago, about 70% of the people who die are actually African American, where it's only 13% of the population. It doesn't seem to affect as many Hispanics in Chicago. Maybe differences in how people are living, how closely they're living, something simple like social distancing, and also the jobs that people are doing and whether or not they're forward facing, seeing, having to go to work and environmental services to, whatever kind of delivery services, you name it, the people who have these kinds of jobs are being put at risk. But then the question is not just who's going to get the disease, but who's going to handle the disease very well. So before I keep going on and on about the risk factors and dying, I have to throw something in because I've seen a fair number of our vegan people, vegan activists, vegan physicians saying, oh, don't worry, the vegan population is perfectly fine. There actually is good medical evidence that viral illnesses are less severe when you have lower levels of inflammation and higher levels of interferon, which is typically what happens when you have a good vitamin and mineral plant-based diet. No question about that. But I don't want people to think that they are somehow immune from getting the disease. If you look at the Icelandic experience, about 50%, where they actually tested everyone, 50% of the people who were positive had been completely asymptomatic, which means that if you're one of those people as a vegan who, they'll get a flu once every other year and it lasts for 12 hours, which is a typical vegan experience. Oh, I used to get sick all the time and now I don't get sick. Well, that just means that you're a symptomatic carrier. So please do the same social distancing and the same precautions that everyone else is, because the life you save may not be your own. It may be someone else that you transmit the disease to because you're vegan and they're not. Okay, so now back to my real theme, which is those risk factors. How do we get diabetes, hypertension, and obesity? It really is nutrition. And so we've been talking about it for years. You've been talking about it, Chef AJ, and we have this whole group of people who have worked really hard to try and get the American population. I was doing it, with my catchphrase of wanting to be number 2, having heart disease not be the number 1 killer of Americans. There's so many countries where it's no longer the number 1 killer. Most westernized countries, it's not number 1 anymore. It's number 1 in low and middle income countries. However, we're still there. There are a few other westernized countries where we're still there, and we have to focus on the diet. We have too much high fat, high sugar foods, the red meat that gives heart failure and gives diabetes, independent of its effects on weight. All of these things are contributing to systemic hypertension, and these are the risk factors. So what is it about COVID? So it turns out this virus, even though you get it in your upper respiratory system, it does not really like the upper respiratory system. It likes the lower respiratory system. It uses what's called the angiotensin converting enzyme 2 receptor to get into cells. And that, I know that scared everybody because they thought that their ACE inhibitor or their angiotensin receptor blocker was somehow going to hurt them. Turns out that's not true. That seems to be helping, if anything. And we'll look for more data on that. But what's clear is that those ACE2 receptors allow the virus to get into the cell. And it turns out that the male testes is a big expressor of that. And so you get infection and reproduction of the virus there. You get it in the kidneys. It really does attack kidneys. And you'll see all of our COVID patients tend to have a rise in their markers that say that the kidneys are going bad. And as they recover, those recover as well. But what no one's thinking is the so-called adipocyte. I'm not sure if everybody's ever heard that term, adipose tissue, or they're basically fat cells. And some people have heard, there's brown fat and there's white fat. And there's a lot of inflammatory tissue or chemicals inside of those cells. Well, it turns out that that is the perfect reproduction environment for the COVID virus. And so it loves to infect the fat cells, grow in that environment, and then express the so-called cytokines, which are these, your body's attempt to defend and ward off invaders that goes insane. And actually the so-called cytokine storm is actually what's harming everything from lungs to multi-organ system failure, as we call it. And people are getting really, really ill because of that. Well, it turns out that there are adipokines that are actually turned on and expressed by the infection in the adipose tissue. So people who are overweight, people who are particularly obese, particularly a body mass index of more than 35 kilograms per meter square, they are actually getting these infections. They're having much more of a viral load. They're shedding more virus and spreading it to more people. So if I had to pick, a population to try and fix the diet ahead of time, it really would have been our African American and our Hispanic population, where obesity is so common. And if 80% of our women are either obese or overweight, it's going to be a particular problem. Men are not that far behind. And so I know it's easy to sort of say that all of the things that we've been saying were so true, and this isn't an I told you so minute or moment, but it is a time to say that we need to prepare for going forward, that this is not going to go away. If we look at what happened in the Spanish flu, there were second and even third waves. London was particularly hit badly with the second wave, and it happened in the United States as well. And so we can argue about social distancing and personal protective measures, but how about making sure that we don't have the risk factors? And let's fix the diet. Let's start today. I'm pleased to tell you that I just got off my email with a patient overweight patient who was struggling with blood pressure. And so we tried to fix the diet. And in 4 days, her blood pressure actually came down so far that she couldn't take her medication anymore. So instead of 160, it was 97/67. And that's what happens when you do a plant-based diet. Now her weight is going to take a little longer than that, but at least the blood pressure risk factor can be really improved so dramatically, very quickly, by following our American College of Cardiology, American Heart Association hypertension guidelines. It says, plant-based nutrition is best. It raises the amount of potassium you get, lowers the amount of sodium you get. And if you can fix the blood pressure while you're fixing the diabetes and the obesity, then you're going to be better off but not just now, but during that second wave. Okay, I know that was a lot to say, but I had to get that out there.
This was great. Listen, please keep talking. People are really loving this, and they're so appreciative of what you're saying. There's a question from Christina. Are there any studies that you know of where they're actually looking at diet and the pandemic?
Absolutely not yet. So we would like to see all kinds of dietary interventions, but all we have right now is the observation, and one of them was published about 8 days ago from New York. That is, if you want to pick out the patient who's going to be intubated on a ventilator, it's going to be the obese people greater than 35 body mass index. And so, yeah, I know that it's kind of like we're saying, here we found a problem. We can't fix it all of a sudden, but we certainly can fix it going forward. But the real question that I have in my mind is, rather than just having anecdotes and rumor mill among the vegan population, I'd actually like to do a survey. Do you know any vegans who got it? I do. I know 2 vegans who got it. Did they both survive it? Yeah, absolutely. And were either of them hospitalized? No.
Yep. So far, I haven't known any pure vegans that got it, meaning like 100%, or people that were really eating the most health promoting of the vegan diet. So yeah, it'd be interesting to see. I used to be, before a chef, a respiratory therapist, and I never remember having to put somebody on a ventilator even for a flu. And now this is I think the scariest part of it, like you mentioned, the lungs.
I'm so glad you mentioned that, because we have so many people saying that, this is not that different from the flu, but it really is. And the big differences are the degree of inflammation, the degree of mucus production. So the mucus plugging is just really defying the ability of getting oxygen across. You also, when I was on the COVID unit, I hadn't seen it in the literature, and this is obviously something that we will study at Rush University, putting all of our data into a database. But the one thing that struck me about every COVID patient is that after a few days, their albumin level was really low. That albumin is really telling you that they are having a real problem with either they're losing it from the kidneys, they're shutting down production, and that gives you what we call capillary leak, meaning that you're going to get swelling in your hands, swelling in your legs, and why not swelling in the lungs as well? And so part of what we call the adult respiratory distress syndrome, of ARDS, has to do with that capillary leak as well. And having your albumin cut in half is not helping that. So, when we put that together with the fact that there's this coagulation storm, and that hopefully everybody's figured that out by now, that there's clots in the legs, they go to the lungs, there's clots in the brain, there's clots in the lines. You're trying to give someone medication to save their life, and the line clots off. And so pretty much that message has gotten out there. And for the last 4 weeks, I think pretty much everyone around the world is using blood thinners. But we put all of those things together, and it makes it really tough on the lungs. So that's why so many people are ending up on ventilators. We're doing a lot better these days by putting people in the prone position, laying them on their stomach. It not only changes the way the oxygen is going to them, but it also clears the lungs. It allows gravity to drain more of the mucus.
Yeah, I mean, I have the utmost respect for everybody that's working in a hospital, and frankly, I'm glad I'm not a respiratory therapist anymore. If I ask you a question that you don't want to answer, please don't feel obligated. But you did mention that this is not just like the flu, and we have a vast array of opinions from doctors in general, but plant-based doctors in particular, as to how serious this is. And if you're willing to speak to that, where do you stand on that spectrum?
Well, I would. I mean, so probably the way I would sum it up is a line I've learned from my kids. I know they didn't originate it. I looked it up, but that whole idea that your idealism is directly proportional to your distance from the problem. I would say anyone who thinks that this is like the flu, come swap with me, come on my rotation, and be the ICU doctor. Not easy for the cardiology faculty to be deployed as hospitalists and intensivists, but that's what we have to do to support our intensive care physicians. Once you see the cacophony of illness, of organ damage that's happening, particularly in the lungs, but not confined to the lungs, it would change your mind completely. But I think, to be honest, after that initial flurry of a lot of folks saying that this is a lot of hype and it's not warranted that we do all these precautionary measures, we actually are seeing people come around and recognize how different this is, how infectious it is, how fatal it can be without proper management. And ventilator management is so key. And if you don't have the intensivists in your area who know exactly what they're doing and changing the parameters of the lungs to avoid the ventilator-associated pneumonias, the ventilator-associated trauma to the lungs, if you don't have those folks who are really expert in this, the outcomes are not so good. And in some places, unfortunately, particularly in New York, where the expertise level is extremely high, the mortality is still very high. And so this really is not the flu. There's nothing like it. And I think people are now publishing statistics and saying, here's what happened with the flu mortality. This is what's happening with the COVID mortality. And so people will understand that, people really do need to take this very seriously.
Well, thank you for going on record saying that in a very articulate and understandable way. I really appreciate it. What you had mentioned is something that I recently interviewed our mutual friend, Dr. Terry Mason, that there's a disproportionate amount of African Americans getting it because they seem to have a higher rate of these lifestyle diseases.
Yes. And so I don't want to discount the socioeconomic factors, but I have a good friend, Dr. Regina Benjamin, who was Surgeon General, and I was watching her on CNN, and she was very righteously saying, don't blame the victim. But I was kind of thinking to myself, well, don't be the victim. Okay, let's change the risk factors. We may not be able to socially distance as well as folks who have better finances. We may not be able to avoid the job, having to go. I was really hurtful to read about the meatpacking industry before they shut down, and how they were really either incentivizing or threatening people's jobs if they didn't come in. And the lady who came in, and even though she'd been sick for several days, not only did she infect other people, but she ended up passing away. There are people on the lower end of our socioeconomic scale who cannot afford to stay home. And that really does play a part in spreading the disease. And if you present late because you're in an area where you're not comfortable with the healthcare, or you try to avoid it, you can end up with a worse outcome.
I appreciate you saying that. I live in what's called the Coachella Valley, and there are several cities that go all the way from Desert Hot Springs and Palm Springs all the way to the east of India, where I live in Coachella, and it's exactly proportional to the income. I mean, we're not making these statistics up. The people that don't have the money that have to go to work, there have an increased rate of getting it and also dying from it.
Right, absolutely. So I feel very fortunate to spend some time on the COVID unit, some time on the inpatient unit, but most of the time I'm actually at home doing clinic visits on the phone, which is why I have to go in a little bit after the clinic. But
absolutely,
we sometimes the luxuries, the ability to actually work and have your job be productive and still help people, as a physician is great. I think the effect that this is having on telemedicine is probably going to be permanent. But then there are other jobs where you just don't have that option.
Absolutely. And also people that are of a lower socioeconomic status, they don't have the money to eat a lot of times, or sometimes it's just also a choice, but the healthier foods, and they're not eating as well as people that have.
Let me dive into both of those. So those are so big, important. And I know you know all this, but maybe not all of the audience knows. You talked about the finances for food. And their own choices. And I'm always trying to tell my patients, you have to choose your food today as if you want to live tomorrow. And that really isn't just something that's in theory. That is, every time you drink a sugary soda pop or eat a sugary donut, that actually causes inflammation. And that inflammatory state makes you more prone to all sorts of illnesses, particularly heart disease. But in this particular epidemic or pandemic that we're in, it puts you in a more difficult metabolic state to fight it off. And so you do need to make some better choices. However, the other part of what you said is really important. I'm not sure of Representative Blumenauer. He was in Oregon a few years ago. He came up to me at an American College of Cardiology meeting, said he really would like to get the college to help with the issue of subsidies for unhealthy food, that our government was spending about $1 billion on subsidies and making certain products that are extremely unhealthy in terms of containing a lot of high fructose corn syrup. And the hydrogenated oils are not as big of a deal anymore, but the refined flour, these are things that are inexpensive, as you say. They're cheaper because of the way our society supports their manufacture and production. Suppose we just flip that around. And I know it's a lot of difficulty politically to do that, but if we could flip this around and say that we are going to incentivize the production of healthy food. We've all heard the stories of Finland doing this, trying to not be the #1 heart disease place in the world and going from dairies to berries. And it's a great story. And I wish that all of our countries that are living in the other pandemic, which is cardiovascular disease, would follow their lead. And if we could get rid of those subsidies for unhealthy foods, our population would be better off.
It seems like whatever the pandemic is, you're always the first responder.
Indeed.
Yeah. You have some great sayings. I love that, from dairies to berries. And then you just said you have to eat today the way you want to live tomorrow.
So yeah, I was actually in a clinic visit, as always. That's where these things pop into my head. And I was dealing with a young man who actually came to me as plant-based after his heart attack. And he had seen some videos or the like and come to me. And I was really counting on my vegan population. Most of them don't go back because they know what the stakes are after a heart attack. Everybody says, oh, nobody changes their diet. My clinics, they all change their diet. Why? Because something bad happened to them. It's a teachable moment. And so this time he had gained a lot of weight. His blood pressure was up, his cholesterol was up. And I said, what happened? And he said, well, he was feeling down about a few things, and he started, eating things that he knows he shouldn't. He was hoping that the medication could cover him. And, we actually have had a wonderful article about that. It was published by Neil Stone. We interviewing him in the International Journal of Disease Reversal and Prevention. And it's where Neil Stone talks about which arm do you want me to cut off? He says, I'm here to help you with lifestyle and with medication. And if you really need it, you really do need both. And so, I was trying to sum this visit up for this patient and say, yeah, we can continue to do prescriptions, but it's really not fun to be the doctor when the patient walks in and says, here, doc, give me something so I can go back and do all the things that got me to your office in the first place. So you really need to make your food choices today as if you want to live tomorrow. And it seemed to resonate with him. And so I'll just keep preaching that.
I love that. People are saying, you're so inspirational. What a class act. The comments go on and on. One of the sayings that you coined that I love, when I introduced you, I said that you're known for, because other doctors are quoting you, is that there's two kinds of cardiologists, vegan and those that haven't read the data. Could you almost say that about almost any specialty in medicine?
Unfortunately, yeah, it turns out that the leading cause of physicians, including cardiologists, is actually heart disease. And we can't, it's tough to get my age. Have so many colleagues who I've worked with in the past, and and this is including presidents of other medical societies that I've worked closely with, and have them have a heart attack, and in some cases actually pass away. It's devastating. When I've eaten meals with them, and they're eating red meat and I'm eating tofu, and we're having a discussion about it, and then I somehow wasn't effective enough to change their eating habits, and then they pass away, a year or two later. And so I do take it very seriously. I'm hoping that we can continue to get the word out. We're not alone. We do have a growing number of plant-based physicians, particularly in cardiology. Starting to see people get into positions where they can really get the message out. And I'm hoping to see that grow fruition over the next few years.
Yeah. Molly says she likes your calm professional manner. Honestly, your voice is so soothing, Dr. Williams. Maybe you could make some meditation tapes for people during this time of stress. I read an article where you actually had a patient come to you, and I guess they were on the Ornish diet, and you were amazed at what happened.
Oh gosh, that was really one of those sentinel moments in your career where, and I talk about it incessantly for a while, but no one's asked me about it. But before I became a chief of cardiology, I was running a nuclear cardiology lab. And it turns out that nuclear cardiology is one of those areas where you can assess the blood flow to the heart non-invasively. And so Dean Ornish had indeed published literature, and so had Dr. Esselstyn, about the effects of plant-based nutrition on the blood flow as shown on a nuclear scan. But I hadn't paid too much attention to it. I'd heard of it, but I hadn't paid too much attention. And it turns out that on my American Heart Association diet, it turns out that my LDL cholesterol was very high. And when I found that out, it was about a week after I'd had this interaction with a lady who had come to my lab. And we normally, one of the best things about a nuclear scan is that you can compare an old one and a new one. And when you do that comparison, you can tell the clinician who's ordering the test exactly whether that patient is getting better, getting worse, or staying the same. Well, her scan was dramatically better. Now, I've seen that before, but it's usually in the setting of having had bypass surgery or a stent. And in her case, it would have been at least 3 different stents because it was 3 different arteries. And we try to collect that information and be very clear about, this person had an intervention at time 0, and now it's, they're following up and this is the post-operative scan. Well, none of that data was there. And so I'm saying, well, our staff must have somehow missed the stents. I looked in our records, there was nothing there. So, well, maybe she moved over to another institution and had a bypass. I don't know. So I actually called her on the phone so I could actually get the report exactly right. And she said, no, I didn't have no stent, no bypass surgery. All I did was the Ornish diet. And so I immediately start looking it up and see JAMA articles, the Journal of American Medical Association, where Dr. Ornish has published very clearly that if you do plant-based nutrition, you will decrease the amount of plaque in your arteries, and you will therefore improve the blood flow. So I had a really good introduction to this before I found out about my own cholesterol being high, and of course went plant-based, knowing that whatever disease was about to get me was going to be a little bit better and a little bit later, at least.
That's great, thank you. Sunny asks, does having high cholesterol and high triglycerides count as having heart disease, or do you have to have more invasive things going on?
So really good question. There's several answers. One of them is that your lifetime exposure to LDL cholesterol, that's the low density lipoprotein or so-called bad cholesterol, is really one of the best determinants of how much coronary heart disease, carotid disease, erectile dysfunction, peripheral artery disease you're actually going to have. And so as it turns out, we have learned some lessons over the years, and we don't rely as much on the total cholesterol as we did decades ago because of 2 studies published in the last 3 years that are saying that the high density high density cholesterol, HDL, as it turns out that it does not protect people when it's very high. We knew that it was a risk factor when it was low, but your total contains, your total is high because your HDL, so-called happy cholesterol, is high, then we were always telling people that they were okay. And that turns out it's not true. A study out of Copenhagen, another one in Canada, showed very clearly that high HDL actually correlates with heart disease. And it's hard to take back something that we've been saying for 40 years, but we have to fess up that, we're learning all the time. And that's the good news. But the bad news is that we were wrong on several fronts, and that was one of them. So what I would say is the most important thing is everyone should know what their LDL cholesterol is. Now, the triglyceride level is really dependent on lifestyle. And so I'm so glad that most physicians have heard the news that we should not be doing fasting lipid profiles anymore, because if you do, you're going to miss the fact that someone's eating horrible food and then has a really high triglyceride that you won't know anything about. if you do every single specimen fasting. So it turns out that the triglyceride level, when it's high, it can do a lot of strange things, pancreatitis if it gets really high. But the one thing that's really vexing about it is that it makes your LDL more likely to go into the arteries. It increases LDL density. And I know that sounds really technical, except a lot of people have actually heard this because they're going and they're getting their particle size done. How dense is your LDL cholesterol? And it turns out that if you get a whole food plant-based diet without the refined carbohydrates, without the frying, taking a wonderful potato and then frying it, and then doing the exercise at the appropriate level for what your risk is, your triglycerides should be about your shoe size.
Wait, your cholesterol should be your shoe size?
No, your triglycerides.
Your triglycerides. Okay, wait a minute. My shoe size is 8.
There you go. No, I'm obviously making a little bit of hyperbole, but
I'm taking what you say literally because my IQ is actually higher than my cholesterol.
There you go. I'm glad to hear that.
Yeah, and my LDL is 57 the last time I checked.
That's wonderful. I'm glad you mentioned that one because, and hopefully you don't have any heart disease, but what happens is we keep changing, what's a good LDL? Well, it used to be 130, then it was 120, then it was 100, then it was 70 if you had disease. Now we're actually trying to get everyone by the European Society guidelines, which are the most recent guidelines. You'd like to see it less than 55. So hopefully everyone will take that to their doctor. But that's only if you have known disease. If you don't have any disease, if you're less than 100, you're going to be fine.
Oh my God, because I'm very conscientious. So if you say it has to be less than 55, I don't know what more I can do, but I want to hit that number. But my family had a history of heart disease, but as a 43-year vegan, I can tell you the reason I know I don't have it. I was hit head on by a driver. My car was totaled, and I can't remember if it was called a CAT scan or MRI, but anyway, they saw my carotids. They said they couldn't believe it. How can you be 60 and have? They said they thought they never saw it. They said there's nothing in my carotid artery, so I'm guessing I don't have it.
Fantastic.
That's great. You had mentioned the risk of being overweight and obese for all diseases, especially the one we're dealing with now, and that I would love for you to be a guest on the Truth About Weight Loss Summit this year because you have so much to add to the conversation. But Layla has a question. What about people that are underweight or very underweight? Are they also at higher risk for COVID-19?
Unfortunately, there are a lot of people who are underweight for a specific medical reason. And if those, including cancer or rheumatoid arthritis with those wonderful disease-modifying drugs that they warn you about on television, you can get infections. If it turns out that anyone who has some compromise of their immune system is going to be at risk. Now, it does turn out that there are some drugs, some immune-compromised people where they're taking something for lupus or rheumatoid arthritis. And one study said that they actually are not at increased risk of dying. That's really glad to hear. The idea being that their immune system was already revved up, and then you're giving them something that suppresses it. And maybe that suppression actually protects them through this COVID storm of inflammation that happens. So it's all theory right now, but we will learn more and more and more about this. But if you're underweight for a good reason, that is you're a marathon runner, you're doing a whole food plant-based diet, you just have a low body fat, you're probably going to do pretty well. But if it's an illness, then I would have concerns.
Thank you. Janet wants to know if a 60-year-old who's a type 1 diabetic that already has heart failure with part of the heart not working could improve or reverse it with a whole food plant-based no oil diet.
So I would actually refer you to the work of Kate Marsh, and we just published this in the International Journal of Disease Reversal and Prevention. And you can actually go on ijdrp.org and download the article where I interviewed her. She actually talks specifically about being a type 1 diabetic and getting into nutrition as a way to mitigate it. And there are a handful of people in our space who really say that they can not get it to go away necessarily, but they can control it better with a whole food plant-based diet. Now, that's a bit different than type 2 diabetes. Type 2 diabetes, most of them have plenty of insulin. The insulin is actually too high. Their problem is insulin resistance, and that is because of the excess in the fat cells. And so, when you say that COVID-19, for example, is attacking diabetics, are they attacking the diabetics or are they attacking the people with central obesity? who happen to be diabetic as well. That's the kind of research that we'd like to actually ferret out and find out. It may be that, Hispanic race and or ethnicity and Black race have very little to do with it. It's more about the economic issues and more about the adipose tissue. And so I would say that we have had some folks who, with counseling and changing the diet, can control that type 1 diabetes really well. And I'm really glad to see that. But on the type 2, you can actually get it to go away.
Yeah, absolutely. I know you're doing some telemedicine now, but we can't see you, right? Like we have to go to Chicago.
No, actually, this is so funny that I have had people see me on a video and they want to come and see me. And I've had them fly in from Dubai and Sao Paulo, Brazil. And I'm saying, I've been asking Rush, can't we figure out a way to do televisits so we don't have to do it that way? And now they figured it out. So
I'm okay right now, but I mean, the thought that I could see you how do we do that?
You just call up Rush and make an appointment.
Oh my God. So guys, you get, I do my best, Dr. Williams, to answer everybody's question, but this is like a New York stock ticker tape. It goes so quickly. You guys, guess what? This is great. Thank you so much. And I'll put the link in the show notes to the phone number, and so that it'll help the people do that. Thank you so much. This is the most exciting thing I've heard. This is tremendous. Judy wants to know if you could please address low HDL when all the other numbers are okay. Because they always complain that my LDL is too low. I think it's like 24 or 36, and I exercise a ton, and I don't think I can eat any better. But the way I heard it was that the HDL is like the garbage trucks, and if you don't have garbage, you don't need garbage trucks.
I really like that. And that does go a long way to explain what I was going to say, which is that we have all this data on low HDL being a risk factor for heart disease, right? But when you do a plant-based diet, your HDL tends to go down, and yet your risk is going down further still. So what is that disconnect about? Well, mostly because it's about the LDL. And yes, a HDL does do what we call reverse cholesterol transport, trying to take LDL out of the cells. But just like you're saying, if you don't have excess LDL to take out, you don't need it as much. And so it seems to work pretty well. I have to put one more comment in there, sort of humbling about our HDL experience. There are loads of drugs like torcetrapib, dalcetrapib, niacin, the fibrates. I just go on and on and on, naming drugs where we did a trial that was specifically designed to help people whose HDL was low. And they were all successful at raising the HDL, and not one of them lowered the death rate or the heart attack rate. And a couple of them, the death rate was a hair higher. And so have really learned to not mess with HDL. It's probably a risk marker rather than a risk factor, despite all we know about so-called cholesterol efflux. And so it is a little bit humbling, but hey, that's the way medicine is. You have to live and learn and try to keep helping the patients with the best of evidence.
Great. When you were the president of the American College of Cardiology, how well received were you by your fellow cardiologists? Did they revere you like we do? Or did they say, he's a crazy vegan doctor?
I'm sure there was a little bit of both. And so the question is, if I could just rephrase the question, is was I able to have an impact? And the answer is yes, that it took a while, but we have plant-based options. And it wasn't just me pushing. There was a fair number of, I like to call them my American College of Cardiology vegan mafia, where we really were pushing to try to get healthy food. It's interesting that they would always bring me, because I was incoming president or past president, they were always bringing me good food, and everybody else had to struggle. But there was one point that we had 5 vegan vegetarians on a board of 13 people. And at that point, they got the message, we're going to have heart healthy foods. So then it became that each one of our meetings would have vegan options. And then we've had a couple of meetings where there was nothing but vegetarian food available. And so I do feel like we've made some progress. More so than feeding ourselves at meetings, I was able to put together a collection of very nutrition prevention minded folks who now comprise our nutrition work group inside the prevention committee. And these are all people that you would know, like and Andy Freeman and We have Esselstyn, we have Ornish, we have some wonderful people, Eugenia Gianos. We have really a lot of people that you've probably spoken to, Rob Osfeld and Danielle Bellardo, and they're really great at putting together the data. Steve DeVries put together that data from our committee, or on our work group, on, unfortunately, the education of cardiologists in terms of nutrition and how bad it was. That was a major publication that we all refer to say that we really need to make some changes into medical education for the good of ourselves, our families, and our patients.
Right. Well, I talk to people who their cardiologist actually tells them to go on a low carb diet, like even a keto diet. And I hear there's even some vegan cardiologists now that are recommending keto diet. How do you feel about that?
So I would refer them to the Seidelman article, which is Lancet Public Health, published September 2018. Refer to it a lot because it was very clear that if you do that kind of diet and you're using an animal-based keto diet, you will increase your mortality. They said 18%. That isn't exactly what we found in the other literature. They were 22, 31, 53%, but the 53 was if you did it after a heart attack. No one should be doing that. However, they also showed that if you did a low carb diet with plants, that you actually did decrease mortality by 18%. And so I think that is what that captured some part of our vegan community in cardiology to say, we're going to go ahead and try that. I think it's reasonable. I'm always struggling to keep weight on because I work too much and don't eat, and exercise all the time. But for most people who are struggling with weight, maybe that is an option. At least, it's not prospective randomized trial proof, but it's observational data that at least supports that can be a healthy pattern if it's made out of plants, not animals.
Terrific. Well, I didn't know that you struggled to keep weight on. So to thank you for being on this broadcast. I'm going to send you my secret weapon that many of the plant-based doctors order from me. It's a special cookie that I promise will make you. Thank you.
Add those pounds. Yes.
They're high in fat. But speaking of fat, we do have some questions on nuts and heart disease.
Mm-hmm. So interesting area, and those who follow a bunch of us on Twitter saw this big fight come up. Oh my goodness, it's ancient history now. COVID sort of just overwhelmed that battle. It did get a lot of press in the vegan community because it degenerated into personal stuff, which it never should. We can always agree to disagree, but we don't have to be disagreeable.
Not everybody's as classy as you.
Well, I try to moderate it by saying, listen, you all are arguing about nuts and seeds, no oils, this and that. But the reason that you believe in your own diet is because you've seen how it helps patients, and you're all correct. And so the reason that you're all successful is because there's no animals. And so within the vegan community, it's a good idea to really try to rely on randomized trials rather than just the science that we think of. I'm always, I've actually talked about it a couple of times, the HDL business. How many times have we been wrong in medicine, in cardiology, about how we treat heart attacks and things like that? And so I've always got to keep an open mind. And I would say that until we do prospective randomized trials of the alpha-linoleic acid or the EPA oils, or using nuts specifically, doing seeds, until we do randomized trials, there's always going to be this room for variation that people are going to feel very passionate about. And they're passionate about because their particular version actually works.
Thank you. That's wonderful. Have you ever thought about being Surgeon General?
So I had a good friend who was Surgeon General, Regina Benjamin. She's, but I did not envy her job at all. It's a tough position to be in, and I wouldn't want to give up what I'm doing here at Rush. Rush is a wonderful place. I should mention that in case anybody's watching, about how Rush University, I didn't actually know this when I took the job 7 years ago, but they had this big, beautiful new hospital. You can look it up. It looks like a butterfly. And so what is that all about? It turns out that there was a lot of funding that came from government agencies in case there were disasters and biohazard disasters. So a lot of negative pressure rooms and underground water tanks and all of the stuff that was really designed ahead of time. And the ability to take a recovery room or an endoscopy suite and suddenly within 2 hours turn it into an intensive care unit. And so that's what I was covering, is one of those pop-up intensive care units. And that means that we at maximum capacity have 175 intensive care unit beds for COVID people, which is about a quarter of the entire state of Illinois. So that's the good news. The bad news is that means we've been taking care of the almost 20% of with all the hospitals in Chicago, 20% of the COVID patients are actually at Rush, which gives us a lot of experience. And hopefully we were going to leverage that into some science that gets published down the road. But right now it is very tough on my faculty and my cardiology fellows, particularly our medical intensive care unit people, the pulmonary division, everybody's stepping up. They said it was, all hands on deck. I was saying it's kind of like all hands on all decks, but we're doing the best we can, and hopefully we'll get through that. But if anybody wants to help out at Rush, just give us a call.
That's amazing. Gosh. Yeah, I don't know if you know this, I'm born and raised in Chicago, and good people come from Chicago. I will say that for sure.
Oh, fantastic.
Yeah. And I love just the way you are without, you're just so inclusive, and you'd be a great diplomat, be a great Supreme Court justice if you have time. I just think I think your mama raised you right is all I can say.
Well, thanks.
So we have a question from Monica. What is an ideal blood pressure, and is this too low?
That is a little low, 77 over 50. Heart rate of 60 is wonderful. The heart rate of 60 tells me that the 77 is really not too bad if it's not an artifact, because it doesn't feel like the body is missing blood flow, in which case the heart rate would go up. Now,
that's mine. That I just, because people are, yeah, it's me, but
I see.
I haven't fainted yet. And
Good. So if you're not dizzy or anything, then that's fine. So yeah, it turns out that the whole food plant-based diet really does lower blood pressure. That's how it made it into our 2017 hypertension guidelines. And we have been, and in our 2019 prevention guidelines, so as many plants as you can, and it lowers the blood pressure burden. My personal experience was, being African-American, being under stress, freshman medical school, blood pressure 140 over 90. And I'm like, so something bad is going to happen. Reading the physiology books, it talked about sodium even back then. And so I cut all the sodium out of my diet, and wow, my blood pressure went to 125. I didn't have to take medicines. It was great. Well, when I went vegan, it went to 104. And maybe it gets to 107 sometimes, but it stays, 3 or 4 decades later, I've got still no blood pressure issues because of the plants. So I would say, as long as you're feeling not dizzy with that and you're able to stand up and still not get dizzy, okay, then that's actually fine. Okay, so, but anyway, back to the question. Our 2017 guidelines, interestingly enough, there were 17 of us on the committee, if I remember correctly, and we were all being vilified for being in the pocket of the pharmaceutical industry because we changed the definition of high blood pressure. We said that anything above 120 is elevated, and anything above 130 needs to be treated. But we actually put together this table of 7 things. That's 3 different types of exercise, not smoking, making sure that you are not drinking to excess, losing weight, lowering the sodium in your diet to less than 1,500 milligrams per day, increasing the potassium in your diet to more than 3,500 milligrams per day, and the most important of all of them was plant-based nutrition, because with very low amounts of animal products, because the DASH diet was able to show that the less cholesterol and fat you had in your diet, the lower the blood pressure would be. So we put together that table, and we thought that was the message, is non-drug treatment of hypertension. Instead, people thought we were pushing drugs. Not in the least. We're pushing lifestyle.
Wonderful. So salt and sugar, good for the heart, bad for the heart?
So I would think that there are some populations that are not as sodium sensitive. Certainly our African-American population in the United States, very sodium sensitive. So we make sure that people are on as little sodium as possible. There are some isolated diseases where low sodium has gotten people into trouble. But for the most part, for the general population, we need to lower it quite a bit. Now, the sugar, I don't actually see any redeeming value. And that does include the artificial sweeteners. All of them have been associated with increasing mortality, as far as I know, and please, you're the chef among us, and you've got a wide variety of listeners. And if anybody can add to this list that I'm about to give you, I would love to know a sweetener that does not substantially increase insulin levels. That would be stevia, look that one up, yacon syrup, that's a root from South America, and erythritol. But people are always asking that question. So, and I learned these from my friends and colleagues. I would love to be able to expand that list because people want something sweet. I just use, the sweetener that's right in the fruit. If I don't take the juice or the syrup out of a fruit, then it tends to be relatively healthy because you've got the fiber to mitigate that insulin rise.
Yeah, terrific. And now they're saying caffeine, alcohol, good for the heart, bad for the heart.
So alcohol doesn't have, that's probably the one big thing that we thought is that, if you are doing the wine to try to prevent heart disease, the French paradox, as they call it, there probably isn't as good real data for that as we thought, 15 or 20 years ago. I do have a good friend, George Abella, chief of cardiology at Michigan State, who likes to grow cholesterol crystals in a beaker. And the two ways to get them to dissolve are alcohol and Lipitor or statins. It's interesting. But that notwithstanding, we don't have any clinical data that we're improving any heart issues by doing alcohol. Now, caffeine is completely different. That's another one where we said, well, we just have to say, oops. We were telling people for years to avoid caffeine, particularly for atrial fibrillation. That's where your atrium starts going haywire and you're getting these arrhythmias. And it turns out that the best data when you do it prospectively, not observationally, but prospectively, do a trial, caffeine or no caffeine, it turns out it actually prevents some arrhythmias. Why did this even come up? It was started off with a nurses' health study and then expanded to a few other large population studies that said that if you're drinking 3-4 cups of coffee per day, it decreases heart attack, diabetes, and stroke. So whatever we were saying about caffeine probably wasn't true. And we just keep doing it. Being a sort of a data file, I guess that with a PHILE and a FILE, I actually started doing coffee. And I try to do it every day. I don't think I get 3 cups in, but I try to get 2.
Wow. Okay. That's incredible. That's, I'm wondering, okay. But I feel like if you're already not drinking it, why start?
And this that heart attack, stroke, and death thing was kind of big. So,
I don't know. I just, cause it makes me, any amount of caffeine just makes my heart go so fast. And I just,
I'm so glad you mentioned that. So there is the genetic predisposition to that. You probably got it from one of your parents and you'll give it to one of your kids. I mean, it's very definite. It would, if you are one of those people whose heart rate goes and you get really jittery and then you cannot sleep for 15, 16 hours after the caffeine exposure, you should go nowhere near it just because of all that. Still not damaging your heart, but it's still probably not a good idea.
Right. Even chocolate gets me, like, I don't do chocolate anymore either. So thank you for saying that there's going to be difference in people. People are asking about how you feel about statins, both for primary prevention and secondary prevention.
So secondary first. So this is a really important thing that people need to understand is that statins should not, I live in the middle of 2 very strong opposing forces. You have physicians who will prescribe statins and not think about diet, and they're not thinking about their own diet, okay? And then you have plant-based people who are saying that we don't need any statins, and that might be true for some people, depending on what their cholesterol is like. But for most people, for secondary prevention, after you've had a stroke or a heart attack or you have peripheral artery disease, you really do need to get your LDL below 55, as I was saying. And there are very few ways that we can do that. A statin, again, the highest dose can lower your LDL by 50%. Every time you lower your LDL by a factor by 1 millimole, that's the European system, or an LDL of 37 reduction, say from 140 for 38. So from 140 to 102, that's a 22% decrease in cardiac events. And so that's what statins are doing. And so everyone going around saying that statins are, poison, statins are terrible, they're just missing the big picture. I just share with you two things. One is, if you look up the profits of the company that had the brand name for atorvastatin, Lipitor, you look up the profits for 2019, they're off the charts. How does somebody make a massive amount of money when it's a generic drug? Well, highly successful. And since dead people don't die by drugs, it must be decreasing the death rate. And so we've done really well. The other thing I would share with you, my conjecture is that, before COVID really wreaked havoc with all kinds of things, and we'll see how it goes. Since it's taking a lot of elderly people, I'm very worried that, we might be balancing our budget the wrong way. But before all of this, Medicare Trust Fund was supposed to run out in 2026. And didn't know what we were going to do. They were starting to make estimates that, physicians would have a 30%, cut in fees. And this is, none of that sounds fun. Well, why were they running out of money? Well, I would say it's statins. I mean, with all due respect to the stents that we do in cardiology and bypass surgery, and, we had about a 70% decrease in cardiovascular mortality over 40 years. And a lot of that was actually due to statins. So, the worst part of statins, I guess, is if you're the government payer, is that people aren't dead because of them. But if you're the person who's living because of it, I would say that's a pretty good thing. So I would say that, I'm still, having said all that and focused on it because of the audience I'm talking to, I would still say that my biggest frustration is the other side, doctors willing to give statins and not doing counseling on diet, or telling patients specifically, oh, the diet doesn't matter, it's your genes. Nothing could be further from the truth. And
right, so I've heard of even them giving them to children now. Right,
so then you're talking about primary prevention. And so yes, we do have, if we talk about the childhood issues first, we do have genetic abnormalities. There are three major genes, types of so-called familial hyperlipidemia, meaning that it's a genetic elevation in your cholesterol. And as I mentioned, that lifetime exposure to LDL cholesterol determines the risk. For those of you who are interested, you can actually see the familial people. You can sometimes figure out who they are without the genetic test, but it's always best to confirm with the genetic test. They tend to have cholesterol deposits on their eyes, and you can see them on their tendons at times, elbows, and ankles, and very, very high LDL cholesterols in the serum. And so it's interesting that we've known about this for quite a while. I would like anyone who's interested in familial hyperlipidemia to look up the pictures of Mona Lisa, painted by Leonardo da Vinci, and you'll see xanthomas, the little cholesterol collection, and rumor has it that she died at age 35. That's typically what happens when you have a familial hyperlipidemia, having an early heart attack if it's untreated. And so definitely those children should be getting statins. Now, if for the rest of primary prevention, it turns out that we had been giving statins for cholesterol level. And starting in 2013, we changed that around completely. We actually used the ACC/AHA risk calculator. And so everyone can actually see pictures of my daughters on my phone, but I was going to show you that on the iPhone, or your smartphone, you can actually download the software. It's called ASCVD risk calculator, okay? It is the greatest party tool ever. You say, hey, well, so we don't do it with social distancing in parties, but you can do it on Zoom. Hey, Uncle Joe, tell me your cholesterol, okay? And how old are you again? You put in all the risk factors that they could remember, and you will come up with a risk estimate of what's the likelihood that they'll have a heart attack, stroke, or death in the next 10 years? We actually use that to determine treatment for primary prevention. And if someone is after, not before, but after they've done all the lifestyle changes, and that is if they're really at risk, 150 to 300 minutes of exercise per week, no smoking, losing weight, making sure that they're doing as much plant-based nutrition as they can, because you really can get a 40 to 50% reduction in your LDL cholesterol just with the diet if you do it well enough. You will actually see that risk number go down. And so we use 7.5% as sort of an arbitrary cutoff. We go a little lower for starting statins to 5% if somebody has a bad family history, or they do a coronary calcium score and it's really elevated. We could actually, start treating people at 5%. But what we really would like to do is have everyone do a lifestyle, the perfect lifestyle, and then only treat the people for primary prevention who have an elevated risk. The diabetes, the smoking, these are things that you can do something about.
Great. I know you have a hard stop in a few minutes. So the last question from Christy is, does oatmeal really lower cholesterol? And what does Dr. Williams eat in a day?
Okay, so I eat a whole food plant-based diet, and I have to say that I've focused much more on nutrition since I've been home a lot. And I do some vegan deliveries and going to the store and getting a lot of fruits and vegetables. And I'm actually doing a lot of weightlifting and protein shakes. I just don't like being that skinny vegan. Having the speed on the tennis court is great, but I also want to hit the ball like I did 40 years ago. And that power, I got to have a little bit more muscle mass. So it actually is working. I've actually, people are talking about gaining 15 pounds. I haven't gained quite 15, but I've gained at least 10. And it's more solid than it would be. So exercise and whole food plant-based diet actually worked pretty well. I know you're going to send me cookies, okay, but I don't do much in the way of sweets. I do a little bit more now than I did before because I know it jacks up my insulin level so that I can absorb more. And that does seem to be working. So for all you out there who want to lose weight, that's exactly not the way to do it. Because if your insulin level goes up, you will absorb your calories from your GI tract so much better. You excrete less calories in the toilet and you put on the weight. But if you're trying to exercise and sort of bulk up muscle mass, it actually is it is effective to have a little bit in there.
Okay.
So anyway, back to the oatmeal. Yeah, it's to have soluble fiber is really good. Some people don't like the oatmeal because it gets really kind of sticky and all that. That's that fibery kind of thing that it does. And that does help you excrete some of the cholesterol. But it's not just fiber, not just oatmeal. If you looked at David Jenkins' data in the Journal of American Medical Association, he had 2 different articles talking about the portfolio diet. It was a lot of almonds, and it was a plot sterols, and it was a lot of soy protein. But he also had psyllium, which is like Metamucil over the counter. And that actually does work to lower your cholesterol. I was not a big fan because back in the day when I tried it, it lowered my HDL. Now I know better. Lowering the HDL is just part of it. It's part of doing a healthy plant-based diet.
Wow. I really enjoyed talking to you, and I know everyone did, and I want to respect your time, but maybe one day we'll get to chat again because you are just brilliant and you're so kind and just so inspiring. So thank you so much, Dr. Williams.
Oh, thank you so much for having me. It's a tough time. I'm hoping that everybody is staying safe out there, service all your surfaces and watch all the door handles and be careful out there and spread the word, please, about plant-based nutrition because, again, the life you save might be someone else's.
Right. And what you eat, I've got to listen to this again, that comment about what you eat today could save your life tomorrow. So
make those food choices today as if you want to live tomorrow.
That's right. You are a national treasure. And guys, come back in an hour and we have a cooking demo with Chef Ramses Bravo. Thank you again, Dr. Williams.
Thank you. Okay. Bye-bye now. Bye.